Hi, everyone. Welcome back. I'm Dr. Samantha, the maternity mentor, and we're here for another one of our live Q&A sessions that we have every Monday at 9 p.m. Eastern Standard Time. This is my chance to interact with you guys. You can ask questions live. Please feel free to put those into the chat. This is also my chance to answer questions that you guys have submitted onto the videos this week. Please remember, check us out on Facebook, Instagram, and Twitter. Share the channel with your friends and family, and make sure you like and subscribe to the channel. Subscribing to the channel really helps content creators out. And one of the nice things that I can tell you guys is that we now got approved for YouTube Health Platform, which means that you can trust this is verified information. The other thing I want to let you guys know is you can hit the notification bell and get notified of our next video that's coming out. And for those of you guys who stay until the end, I will give you a sneak peek at tomorrow's video. So again, for any of you who are joining us, please feel free to put your questions into the chat. So I'm going to go ahead and I'm going to start with questions that were asked on the channel this week. So the first question that we have came on the antibiotics video. And it says, is cephalexin 500 milligrams safe during the third trimester? So antibiotics are one of my favorite topics. It's very important when you are pregnant that you are checked for infection if you are having symptoms. And one of the big symptoms that we worry about is anything coming out of the vagina. So this is bleeding, which can happen especially during the first trimester and can be caused by infection. It is also any type of discharge, and discharge can be clear, white, green, yellow, gray. If you have any kind of symptoms urinary wise, so when you're peeing, if it's burning, if you have pain, if you have frequency where you're going all the time, these are all things that you want to get checked out. Now, when you go to the doctor, we do a number of things. If we have vaginal discharge, we're going to do a vaginal exam, and we're going to take a sterile cotton tipped swab, and we're going to swab some of the secretions that we see, send them off to a lab, and we're going to test to see if there is an infection and what kind of infection are we dealing with. So it could be bacteria, it could be normal stuff, it could be viral, fungal, yeast. Now, if you have urinary symptoms, we're going to get a sample of your urine and we're going to send that to the lab to see if you have a urinary tract infection. Untreated infections are one of the leading causes of preterm birth, miscarriage, stillbirth, small for gestational age babies, complications, etc. That's why it's so important for us to go ahead and treat them. Now, cephalexin is an antibiotic. This means this is a medication that is designed to treat and kill bacteria. So if you have a fungal infection, a viral infection, a yeast infection, cephalexin is not going to help with that, which is, again, why it's important for us to identify what's going on. When you have a bacterial infection and you are taking an antibiotic, you need to take all the antibiotics as prescribed by your healthcare provider. Women, when they're pregnant, they're very hesitant to take anything because they're worried about the baby, which is a good thing. However, one of the things you need to know is that when you're given something to treat an infection, it's very important that you take it all as prescribed. So here's what happens. If you think about bacteria, they have all these lines and lines of bacteria just trying to attack your body, okay? So when we give an antibiotic, that antibiotic starts killing off the first rows of defense. But the guys in the back, they're paying attention to how that antibiotic works and what it's doing to kind of, out guys in the front. And they start figuring out how to build a defense. Now, because you're taking out all this bacteria, 24 hours, 48 hours into your antibiotic, you're going to start to feel better. Whatever symptoms you were having will probably start to go away. But you still have bacteria back here hanging out. If you stop taking that antibiotic, what happens is these guys back here, they build up a wall of defense and then they start multiplying and bringing in more and more bacteria. And before you know it, you're sick again. But when we give you that same antibiotic, or if you say to yourself, oh, I should have finished taking it, you grab those pills and you start taking them again, it can't get through that wall of defense. And now these bacteria continue to grow. You get sicker and sicker, and the medication won't work. That is antibiotic resistance. That's when an antibiotic no longer will work to treat an infection. And this is why it's so important nowadays that we're trying to educate patients that if you take any kind of medication for an infection, you need to take it in its entirety from start to finish. So if you've decided to take that medication, you need to commit to that medication. Now, a lot of people get very concerned about antibiotics. Antibiotics, I'm extremely passionate about if you have a bacterial infection that's been identified, because most of these infections can lead to preterm birth. If you are prescribed cephalexin is actually, we believe, pretty safe for pregnancy. There was actually one study that showed that cephalexin used for urinary tract infections actually reduced the risk of preterm birth. Now, you got to understand, there's no actual studies being performed on pregnant women. That's not ethical. What they do is they gather data afterwards and they do like a look back to see what the outcomes were when people were prescribed these medications. And that's how we get these studies. But cephalexin is considered very safe. There's no indications that it would cause birth defects. Everything is still a risk versus benefits, meaning you have to talk to your healthcare provider and make sure that they let you know. But cephalexin can be used very, very safely for most people. And I definitely believe that you should take it if you've identified a bacterial infection to be treated. So that was like a really awesome question to start the night. Now, the next question, we had a lot of questions on medications this week, which I think is really great because I think it's sometimes very scary to try to take something and not really know for sure what you're taking or if it's okay. So it says, I am postpartum and my primary care physician gave me hydrochlorothiazide at 25 milligrams. I am currently breastfeeding. Are there any known risks to my infant while taking this? Are there any better options for high blood pressure I should ask about? So this came on the blood pressure medication. And so hydrochlorothiazide is a thiazide medication. The way it works is it actually tries to reduce fluid in your body. So it kind of pulls fluid out. So you take this medication. It's also another name for it is a diuretic. And what it does is it makes you pee. So a lot of people will actually call it their pee pill. And we tell people to take it in the morning because for the first several hours is when you're going to pee the most. We try not to have people take it at night because when you take it at night, it can actually keep you awake at night if it's working right because you'll be up all the time peeing. So it pulls that fluid out of your body. If you're super swollen with fluid, that's going to keep your blood pressure higher. If you have less fluid on board, there's less pressure, it lowers your blood pressure. So this is how this works, generally speaking. It's actually interesting. So during pregnancy, we don't tend to use the diuretics at all. We stick with blood pressure medications. The most common is nifedipine or Procardia, and then the Olols, O-L-O-L. And those are the beta blockers. So a lot of women will be put on labetalol. That's a very common one. And beta blockers are known for lowering both blood pressure and heart rate. So these are the two most common used during pregnancy. If you were put on a medication during pregnancy for your blood pressure, usually you will continue that postpartum. And these medications are safe for breastfeeding. All of them that you would use are still safe for breastfeeding. Hydrochlorothiazide is interesting. So I actually don't see that commonly used postpartum for high blood pressure treatment. My guess is for this particular viewer, she might have a lot of lower leg edema. A lot of women, when they deliver postpartum, within a couple days, you'll see tons of swelling appear in the legs. Very common, usually not a big deal. Usually it will go away. Some actually have to receive treatment through physical and therapy or stuff to help relieve their edema, but something like hydrochlorothiazide can help. Now, hydrochlorothiazide, again, remember, it makes you pee. So it's taking fluid out of the tissues. It is safe for use during breastfeeding. What they've done when they've tested breast milk is they really don't show very high levels, if any at all, in the breast milk. However, as a lactation consultant, I would be having a conversation with my healthcare provider about why they've picked a diuretic, which is going to draw fluid out of the tissues, versus a blood pressure medication like a beta blocker to treat blood pressure, and let them explain to you why they've chosen this. Because you could get dehydrated with a diuretic, and you need fluid and to maintain in order to maintain a healthy breast milk supply. So while I'm not going to say that it's impossible to breastfeed with hydrochlorothiazide, I'm sure there's plenty of women who do it and have a robust milk supply. If you have any other factors going on that might make the breastfeeding not work as well as you would like it to, for example, let's say the baby's tongue-tied and you're having trouble latching. Let's say you have something like polycystic ovarian syndrome, which often interferes with milk supply. If you have any other factors, bringing in a diuretic, which may also dehydrate you, could really tank your milk supply. So I would definitely ask why that's the one that's been chosen. But for example, nifedipine or labetalol is not going to help with swelling. That's not anything it's really going to attack. And if that's what your healthcare provider is going for, then you want to know that. So what is something else that you could potentially do if you have a lot of swelling that's homeopathic? Well, one of the things you can do is walk. If you're cleared to walk, you should be walking a lot, and you can ask for physical therapy. You can actually get physical therapy to help you move that fluid out of your tissues. So that's actually a very real thing. For those of you who are joining us, welcome, welcome. Please feel free to put your questions into the chat, and I will answer them for you live. So we had a question on Placenta Previa, and I love talking about placentas. I think it confuses a lot of people. So I have a Placenta Previa, and I'm in my 13th week of pregnancy. I've had 2 cesarean sections before. Now I have a Previa completely covering the internal os. Do you have any suggestions? So let's start with some anatomy. Here's your uterus, and this is going to be our placenta. And this side of the placenta is full of a whole bunch of different blood vessels. And it attaches to the side of the uterine wall like this. And then this side also has blood vessels. And these two together connect. And that creates this vascular bed. That's what we call it. And that's where all the stuff is going to exchange between you and the baby. That's where your nutrients are going to go to the baby and all the toxins are going to come out. So that's what it normally looks like. Uterus, it attaches to the side. Okay. So now we're going to talk about 2 other terms that some people hear. We have anterior, which is towards you guys, front of the belly, and posterior, which is towards your back. Now, if you have an anterior placenta, as the baby grows, sometimes you'll find that when they go to listen for the baby's heartbeat, they can't really hear the baby's heartbeat, right? And sometimes you'll have trouble feeling the baby kick. And that's because that placenta is sitting in the front part. It's kind of like this big giant pillow, and you can't really feel all that stuff through it, okay? Baby's still totally fine, but you've just got this extra layer in between. So when you have a posterior placenta, oftentimes those are the babies that you can see them rolling around on the front of your belly. Now, most of the time, the placenta is going to go onto the side. At the bottom of your uterus, you have your cervix, okay? So the cervix should be long, thick, and closed, okay? And 2 fingers actually really represent what a cervix kind of looks like and feels like, believe it or not, because it is pretty long, okay? And when I say closed, it can't be completely closed because remember, it needs to open or dilate for the baby's head to come down. So see this little slit right here? This is actually pretty accurate to represent what a closed cervix looks like. And this slit right here is where your mucus plug is. So that infamous mucus plug we all talk about coming out. So you have this layer of mucus here to help prevent different types of bacteria and stuff from going up into the uterus, which could potentially cause uterine infection. Okay. So again, we have our cervix down here. Okay. So this is our uterus and our cervix. Now, a complete placenta previa. What that means is that the placenta is straight on top of this cervix, okay? A partial placenta previa means that it's halfway. And a marginal placenta previa means it's like right on the edge. So you see how your cervix is clear and it's just sitting right next to it. Now, when you first start your pregnancy, your uterus is super small. And as your baby grows, the uterus gets bigger and bigger and bigger and just to expand for the growing baby. If you have this placenta that's sitting right here over the cervix, right when it's a tiny ball of a cervix, what can actually happen is as the uterus expands, the placenta can migrate with it. So it ends up where it can start as a complete previa, and by the end, it can be in a completely normal position, right? So one of the things I'm going to say about this viewer's question, going back to it, is she's 13 weeks pregnant. She's barely entering the second trimester. There is a lot of time for this placenta to migrate into a more normal position. Now, if you have a complete placenta previa, again, it's completely covering, you are going to have a C-section, an automatic C-section. There's no other way to do it. Now, there's two reasons for this. Number one, the placenta is blocking the opening for the baby's head. So the placenta is in the way. The baby's never going to be able to come through that. But second, what happens when you start having contractions? Well, those contractions, right? So here's our cervix. Those contractions are designed to start thinning out the cervix and making it shorter. You see how I'm getting shorter? And then they get to here and then it starts opening up. That's what your cervix does over time from those contractions. And when it opens up, that's the effacement where it gets thin so your baby can come down. When you start that contraction and you're starting to dilate here and this placenta is sitting right here, remember what I said about the placenta? This is all blood vessels. As soon as you dilate, these blood vessels are exposed, you start bleeding out, and the baby starts bleeding out. It is a medical emergency for both you and baby, and we have a very short period of time to do an emergency C-section. So when we have an identified complete placenta previa, oftentimes what we will do is we will bring those moms into the hospital. It depends on your protocol with if you have a midwife, if you have a OBGYN, like where things are at. But most of the time we'll bring those moms in around 34 weeks. They stay in the hospital. Oftentimes you're just delivered at 34 weeks because remember, Braxton Hicks contractions can start the dilation process. And we'll deliver you right then and there because we don't want to take any chance of you going into premature labor, dilating, and having a hemorrhage. Now, what we also sometimes will do is we sometimes will go ahead and we will kind of monitor you. We'll keep track of how the baby's doing. We'll keep you in the hospital, make sure everything's good, and try to keep you pregnant for as long as possible because many women can go almost a full term without ever dilating at all. So as far as what can this viewer do, there's nothing you can do, unfortunately. The placenta will either move on its own or it's going to stay in place and you'll need a C-section. Jade. Hi, Jade. Thank you. Why do hospitals give pushback when you ask to keep your placenta? So I'm going to tell you the reason why I think it is. So one of the things that's become very popular is placenta encapsulation. This is where you can take your placenta, you bring it home, you dry it, and they put the placenta pieces, the dried pieces, they basically make it into a capsule, a powder that's put into a capsule. And then women will take that postpartum. They'll take those placenta pills. The idea behind it is that it can help with like bringing back some of your iron and helping reduce anemia. There's people who will tell you that helps with postpartum depression and stuff like that. So I'm completely against taking placenta pills. I'm very homeopathic. Even though I'm a psychiatric care provider, I have patients who only take vitamins. So I do not just prescribe medications just like that. I believe in alternative medicine. I believe in functional medicine. I'm very supportive of it. I think it's amazing. I am not about placenta pills. So that kind of goes against a lot of homeopathic providers, but I'm going to tell you why. And I think this is why hospitals give a lot of pushback. Long time ago, there was a case of a baby who ended up going to a neonatal intensive care unit. So this baby, it was an innocuous reason. I think it was like a temperature instability or low blood sugar, something like that. Something very, very kind of normal for NICU. Wasn't a super preemie baby. It was like a 37 weeker. So really, it was a full-term baby that they were monitoring because of this minor issue. Most neonatal units will do blood cultures when any baby is admitted. So a blood culture is simply testing the blood for an infection. And the blood cultures take 24 to 72 hours to completely result. Basically, at 24, 48, and 72, each day the lab checks those cultures to see if anything has grown. If something grows, we give babies treatment, but it's like a standard kind of protocol. So this baby is there. The baby's has no infection. There was nothing on the blood cultures. Baby did need a little bit of time to grow. Mom is breastfeeding. Okay, so she is breastfeeding. Baby's been doing well. And about 10 days in, the baby is just about ready to go home, and baby starts doing worse and worse and worse. And very quickly, they have an extremely, extremely sick newborn who actually almost passed away. So, of course, one of the things they did was blood cultures. When they redid the blood cultures 10 days after birth, what showed up was a group beta strep infection. So, for those of you who don't know, when you are pregnant around, it's like 36 weeks, 38 weeks, they will do a swab of the rectum and the vagina to check you for GBS, group beta strep. Group beta strep is a bacteria that can just be found normally in a vagina. It's not sexually transmitted. You might have it for one pregnancy and not another. Some women get tested earlier in their pregnancy. You could have it then and not have it at the end. It's kind of like a random thing, but it's a very normal bacteria. If we find group beta strep, we will give you antibiotics during your delivery. That is to prophylaxically treat that infection, because if it's not treated in your baby, it can become life-threatening, as you can see from the story I just told you. So we give you the antibiotics, and then we will automatically test those babies when they're delivered by doing blood cultures to make sure the baby doesn't have this infection. So going back to the story, when they tested the baby, they were like, wait a second, how is this like happening? And they then reviewed her breast milk and they tested her breast milk, and group beta strep was in her breast milk. When they questioned further, she was taking placenta pills. When they tested her placenta pills had group beta strep. So she most likely developed a group beta strep infection from her own placenta. Second to that, when you're talking about drying out a placenta, since this is not an FDA approved treatment, modality, medication, however you want to put it, it's not FDA approved. There's no studies that prove what people say about it. Nobody can do this for you legitimately. There are OBGYNs who will take your placenta home to their kitchen, who believe in this, and they will make placenta pills for their patients. There are companies that will do this. There are recipes you find on YouTube for this. I mean, you can find out how to do this. There is nothing necessarily sterile about any of this stuff to ensure that this is going to be sanitary and safe for both you and the baby. Again, some of the OBs, if you think about it, they will bring this home to do for their patients. Are they potentially not sterilizing the pot that they use to boil down the placenta between patients. Kind of gross to think about, but it's true. And once I started looking at this more, that's when I realized where I fell on this. I think it's really great in theory, but in practice right now, I do not think it's safe. I think there's a lot of unknowns. Placentas can be full of bacteria and viruses, and they really are dying at the end. I mean, the reason why you have to deliver your baby by like 41 weeks is placentas are starting to calcify and they're starting to degrade. So it's not something that I really am pro. So now going to your question, Jade, I think this is why a lot of hospitals give a lot of pushback, because their fear is if you give the placenta to a patient and something like this happens, that they might be open to litigation liability. And when I was working in the hospital that I was at, the patients would have to sign like a consent, like a waiver, basically. It was very, very specific, and it had a lot of verbiage like, you agree not to ingest it, you agree not to share it, you like all this stuff. It is sad, however, because what I am supportive of is there's many cultures and religions who believe very strongly in the importance of taking the placenta and burying it or doing other types of spiritual practices with it. It's kind of like giving part of that life essence back to the earth. And so I do think it's unfortunate that hospitals give pushback because we don't know why a patient is asking to take the placenta home, and we cannot assume that it is for the use of placenta pills, although that is the most common. But again, for any of you guys who are listening, I do not believe in placenta pills. I do not recommend them. I'm very much against them until it's become a regulated process that has been looked at more carefully. Okay. Obapa, I hope I'm saying that right. You're 17 weeks and 4 days, and you have been having on and off cramps for the past 4 days, sometimes dull or intense. Is it normal or serious? I've been given baby aspirin 81 milligrams to control my blood pressure. Is it safe? Okay, so no, cramps for the last couple of days, you need to get checked out, especially now that I'm seeing the words baby aspirin to control blood pressure. So we have a video on preeclampsia that we're going to link into the description. When you're having blood pressure issues during pregnancy, your body can sense that. Now, the next little bit of stuff that I'm going to talk about is a little intense. So I'm going to kind of give a trigger warning if anybody has had any kind of miscarriage, okay? So up until about 24 weeks, babies usually are not able to survive outside of the belly, okay? They do best when they're inside, okay? And so up until that time, your body is focused more on your health, mom, than on the baby. The baby is taking control, like taking a lot of resources from you. And if the body senses any kinds of issues with the pregnancy, it will sometimes attempt to trigger preterm labor in order to help protect mom. So when you're having blood pressure issues, you're sending out certain signals and your body can sense this. And if you're starting to have more and more complications, your body knows that if the pregnancy was not there, you probably wouldn't have the blood pressure issues. And so sometimes that will trigger early labor. That's why we work so hard to keep your blood pressure under control, because we know this. So when you're having any kind of cramping with blood pressure issues, you need to go to get checked out. You probably should go to a hospital so they can do an ultrasound, make sure the placenta is working, make sure the baby's looking good, and so they can do some blood work on you. Separate of that, the other thing you guys need to know is dehydration is another common cause of cramping and contractions. So you want to go ahead and you want to make sure you're drinking plenty of fluids. But yes, for you, I would tell you to go to the hospital, because right now at 17 weeks, 4 days, you're so close to that 24-week mark. If we can try to hold things off, before you know it, you'll be there and the baby will be in a lot better, position. Hi, Gabriella. Welcome back. I haven't seen you. So you had your 3-week postpartum video appointment. Oh God, I hate that already. I thought that I would have a 6-week postpartum, but when I asked the nurse practitioners, they said they don't do 6 weeks appointments unless I'm bleeding. Is okay. So what Gabrielle is saying is that at 3 weeks postpartum, I'm pretty sure I remember Gabrielle told me she had a vaginal delivery. She had a video appointment and no 6-week appointment. So I'm going to tell you that that has never been the standard, and I think that's totally not normal. And I would absolutely insist on a 6-week appointment, which is pretty much standard because that's when they clear you to have sex and do regular activity. I would also tell you that somebody needs to lay eyes on you. If Gabriella was lucky enough to be intact after her vaginal delivery, so for those of you guys who don't know, and we have a video on like vaginal tearing, but when you give birth, there's a chance that you could tear. And so there's different degrees. It's a first, second, third, and fourth degree laceration is what they're called. And that's a natural tear that occurs. And then there's also episiotomies, and that's where they purposely cut you. When those happen, they have to stitch you up, okay? They have to make sure they close that laceration. And so when they do that, you're left with stitches, and those stitches are supposed to dissolve. Okay. So it usually happens like it's not a big deal. However, we have to check it for a couple reasons. One, we need to make sure it's well approximated. So kind of remember my cervix example. See, my fingers together, if this was a cut, this is well approximated, meaning that everything looks like it's lining up, it's nice and smooth. That's well approximated. But sometimes you'll have an incision that even though there's stitches, there's like a little gap. That's not well approximated. It's supposed to be nice and tight together, okay? Sometimes also it'll be a little jagged. Then, of course, it could be red, it could be swollen, there could be pain, there could be discharge. If you are not sure what discharge is normal or abnormal after delivery, you could have discharge coming from an episiotomy and think it's normal discharge, or that discharge could be hidden in with blood, regular postpartum bleeding. So if there's any kind of repair, we're supposed to look at it at 6 weeks because you are not supposed to be putting anything into the vagina for 6 weeks. So that's number one. Number two, at 6 weeks, they are supposed to bring you in to do a check for postpartum depression. So I'm in psychiatry. Specifically, I do a lot of women's health psychiatry, including depression, anxiety, and all that stuff, both pregnant and postpartum. And so in the first 3 weeks, you're like completely overwhelmed, especially with your first baby, trying to adjust and figure everything out. There's lots of doctor's appointments. There's all this stuff, right? So, and then you have 10 days of what can be considered baby blues. And we do have a video on like baby blues versus depression. We can link that. But like you have at least 10 days really where you can consider it baby blues. So at 3 weeks postpartum, you're still in the haze of like everything. So a lot of women will not screen positive for postpartum depression or postpartum anxiety until the 6-week appointment. So that is also a great time for us to screen. So most of the time we are bringing women back at that time to do, if not their first, their second depression screening postpartum, because they should have done one at the 3-week. Number 3, they need to do your vital signs to make sure like you don't have high blood pressure. They need to ask you questions to make sure you haven't developed a thyroid issue, which is very common postpartum. I mean, there's like a lot of stuff that they should be doing at that 6-week appointment. And then finally, like sex, right? Sex and activity. Well, activity, I suppose they could just tell you, but like sex, like you need to talk about it. You need to know what to expect. You need to know how to do it. And birth control. You can get pregnant at 6 weeks. You can get pregnant at 4 weeks postpartum. I have had patients have that. So before you're having sex, you need to have a discussion with your healthcare provider about what your plans are, because they should be educating you that the WHO standard is 2 years postpartum before you try to have a baby. It's called baby spacing. It's the best thing for your body. So yes, it is weird. And I definitely would be asking for a check. For those of you who are joining us, welcome, welcome. I'm Dr. Samantha, the maternity mentor, here for one of our live Q&As. For those of you who are with us, please feel free to put your questions into the chat like many of our people have done. I will answer them for you live. And for those of you guys who stick with us to the end, I will give you a sneak peek on the video that's dropping tomorrow. And Gabriella, you probably want to know what this one is, although you can just look at we post this video afterwards. So if you have to see it afterwards, that's fine too. I'm going to go on to the next one while we are kind of here hanging out. So I got a question on subchorionic hemorrhages. So how can you differentiate between a subchorionic hematoma or a period with the 2 weeks wait? So not sure what the 2 weeks wait is, but I'm going to go ahead with just subchorionic hematoma. So we had a whole long talk about placentas. We're back to placentas, right? Placenta, uterine wall. So again, this is a whole bunch of blood vessels. And sometimes a little pool of blood will develop underneath. That is a subchorionic hemorrhage. As simple as that. It's a little pooling of blood that's in between the uterine wall and the placenta. You could kind of think of it like what would happen with a bruise. You know, when you hit your arm and you bruise and you get that nice purple mark, what actually happened is a couple blood vessels broke, and that purple is a pooling of blood that you see as that whole thing heals. So you can kind of think like a subchorionic hemorrhage is the same type of thing. It's a pooling of blood. Most of the time, it just goes away. Now, if it's on a kind of an edge of a placenta, some of it will leak, and so you'll see spotting. So this is one of the many causes of bleeding that can be normal. Again, if you have any kind of bleeding, you need to get it checked out so we can figure out what's what. But with a subchorionic hemorrhage, oftentimes that's a very valid cause, and then it just resolves on its own. The other thing that's really scary about subchorionic hemorrhages is that just like your uterus grows as the baby grows, the placenta will get bigger. I mean, you can't have this big giant placenta when you have a little microscopic baby, right? So in the beginning, the placenta is really small, and the placenta also grows, okay? Now, if you have this little teeny tiny placenta here, let me get my fingers kind of there, and you have a tiny, well, let me do this. If you have a placenta and this is your subchorionic hemorrhage, right now, that's a pretty big part of this placenta. But when this placenta is this big, this same subchorionic hemorrhage is now small. So a lot of people get freaked out because in the beginning, they're told this subchorionic hemorrhage is pretty big and all this stuff. But as the placenta grows, the subchorionic hemorrhage stays the same or is shrinking. And then a lot of times it resolves. So that's why we just keep an eye on this stuff. As long as you're not symptomatic, then it's, you know, as long as you're fine, you're not anemic, the baby's doing well, we don't need to worry about it. The only thing I could take from this question is she says, or a period with 2 weeks wait, is I'm thinking she's saying she was 2 weeks pregnant and she's bleeding. And how can you tell if it's a subchorionic hemorrhage versus a period? So the thing I will say about that is, just so some of you are aware, you can actually have your regular menstrual cycle on time while you are pregnant. That does sometimes happen. Sometimes your body needs like a little bit of time to figure out that it's pregnant. And so a lot of women will continue to have their normal menstrual cycle for 1 or 2 cycles. So, you know, the way to figure out what's what, you need to get checked out. And you need to go and you need to get an ultrasound, because the ultrasound is what's going to tell us if it's a subchorionic hemorrhage. That's the only way to know that one. The final question I had from videos, we didn't have a lot of questions this week, I think, because everybody was watching the game, is on depression, which of course is one of my favorite subjects. So, what about the baby after birth? Does the withdrawal cause them to be disturbed? So, this came in on the depression medication video, which I have out. And so, the depression medication that I believe she's referring to is like SSRIs and SNRIs. So, SSRIs, serotonin selective, causes anxiety and depression. SNRI, serotonin norepinephrine reuptake inhibitor. This one boosts serotonin and norepinephrine. Norepinephrine is also a neurotransmitter. This one can also help with depression and anxiety. Okay. So, what are some of these drugs called? In the SNRIs, we've got Effexor, Cymbalta, Pristiq. In the SSRIs are the ones that a lot of you guys are familiar with. Prozac, Paxil, Celexa, Lexapro, and the most common for pregnant and postpartum women, Zoloft, which is also called sertraline. Okay. Now, when you are pregnant and you have depression, you are at risk for a lot of things. You are at a higher risk of miscarriage, a higher risk of preterm birth, a higher risk of having a baby that's small for gestational age. And the list goes on and on. And what we now know is that treating depression and anxiety during your pregnancy actually reduces your risk of a lot of things. It can actually lower your risk compared to a standard woman out there. So it is very beneficial to both you and to baby to get treated and get medicated properly. If you do decide to take antidepressants, you need to be treated to remission. So you don't want to just get the edge off of your anxiety or depression. You want to take it to as close to 100% remission as possible, or all of your symptoms being gone, because that's actually what the evidence says is the best for both you and baby. Now, withdrawal. So when you read about all of these medications online, forget about pregnancy. You're going to get a whole bunch of people who say these medications are addictive. Let me explain why that happens. So when you're under stress, whether it's emotional stress or physical stress, medical stress, okay, your body releases like stress hormones. And these stress hormones over time will start to hit the brain, right? And when they hit the brain, they start to kind of damage the areas that make serotonin, for example. So the serotonin machine in your brain is supposed to be doing all this stuff, and it's not doing it well anymore. So what happens is we have these serotonin receptors, and they're being left empty. They're supposed to be full, but they're empty. And so your mood starts to go down because the machine just isn't working right. And you've got all these receptors that need something that they're not getting, and you feel awful. Now, I come in and I give you Zoloft, and Zoloft increases your serotonin. So what am I doing? I'm filling up the empty spots. So now these spots are full and you start to feel better. Well, the other thing I do when I fill these spots is the part of your brain that makes serotonin is like, whoa, wait a second. I don't have to do this anymore. Wait, are you saying I can go to Hawaii? Like I can go on vacation right now? And it takes off. Now, what do I really mean? That part of your brain gets a chance to rest. It gets a chance to heal because it's not constantly having to do the job of filling these receptors. So when you take something like this medication, all you're doing is giving your body a chance to heal. Now, after a little while, hopefully things calm down for you. You're starting to feel better. Maybe you started some therapy. Maybe you're doing some better self-care. You're feeling better. And now you decide you want to stop taking the medication. Well, if you stop cold turkey, that means you just stop the medication. Well, all of these receptors that were filled by that Zoloft, all of a sudden they all empty at once. All of them. Now, the part of your brain that was supposed to be making this, remember, it's off in Hawaii. It's got a 17-hour flight back. So it's not doing its job. Seriously, it's not even starting it for about 17 to 24 hours. It's got to get production going again. So you, in the meantime, have all these receptors that are open and empty, and you go from great to feeling terrible almost instantly. You can be depressed and anxious, but you can also have nausea, vomiting, diarrhea, headaches. You can be shaky, sweaty. all of this stuff people associate with addiction and withdrawal. You are not addicted to that medicine. We emptied every receptor all at once. Of course, you're going to feel awful. So what do we do as medication providers? We go ahead and we taper you. And a lot of people hear that word, and again, they associate it with addiction. It has nothing to do with addiction. So if I take away a little bit of that Zoloft, I'm only opening up a couple of the receptors. And I say, hey, you need to buy your plane ticket back. Your vacation's over. So your body starts to kick in. But most of the receptors are still full, so you feel okay. Body kicks in, it starts filling those few that I opened up. So now I take away a little bit more. And again, your body goes, oh, I guess I need to do a little bit more than that. And it picks up, take away a little bit more, it picks up. And before you know it, you're back to making your own. Now, how long does that take? I can do a Zoloft taper, specifically Zoloft, in as little as like 12 days. So this is not some long, drawn out months of your life thing. It's just enough to let your body get the signal, hey, I need to get back going. Now let's talk about baby. So if you're taking Zoloft during your pregnancy, the baby does get some of that Zoloft. Okay. Zoloft is safe for your baby from the perspective of it's not been shown to cause birth defects. There's no growth issues, nothing like that. In fact, your baby's getting Zoloft. Your baby probably feels pretty chill. So the baby gets some through the placenta. When you go to deliver, what happens? That placenta detaches and your baby goes cold turkey. And now your baby feels not so great because your baby was getting Zoloft and now none of it's there. Your baby's brain is still going to make serotonin. It's still going to do everything I just described. None of that's going to change. But what can happen is what we have identified, which is a withdrawal syndrome. So babies can have a high-pitched cry. They can be a little shaky. They may not eat as well. They may be very squirmy and sleepy, and they just, generally speaking, may not feel very settled. Usually will last no more than 10 days, and then they will start to feel better. And how do you treat that? You give your baby lots of love. You feed that baby often. So if you're going to breastfeed, you pop a boob in their mouth all the time. If you're going to bottle feed, you give them lots of formula. If you're going to be doing both, you do both. Lots of skin to skin. You do skin to skin. Dad does skin to skin. Grandma does skin to skin. Like lots of just love. Most of the time, as long as the baby's just being very much tended to, babies will do just fine. You may not even notice anything at all. What do we do as providers? Well, when we're medicating somebody for their mood issues, a lot of times, as long as the mom is stable and she is doing well, 36 weeks, we go ahead and we drop her dose. If we're lucky, we can drop it by about half. She stays at that half dose through delivery. The second she has the baby, we increase the dose back up to regular. Now, we also will encourage that mom to breastfeed because there is some Zoloft in the breast milk. So the baby gets used to a lower dose, but there's a higher dose of the Zoloft in the system when mom starts breastfeeding. So a higher amount will be available to the baby. So baby will naturally start to get little tiny bits of Zoloft through there. And then as the baby gets bigger, the baby's actually weight gets bigger and the amount of Zoloft that could possibly be in the breast milk isn't enough for them and they wean themselves off naturally. And that's how we use an antidepressant. That's how we address withdrawal syndrome. And that's how we can keep both you and baby healthy while treating any anxiety or depression that you might have. So I hope that answered that question. It is a very long discussion that you want to have with your healthcare provider if you are considering medication. For those of you who might be struggling with mood issues, I also want you to be aware there's a lot of homeopathic treatments out there. You just need to have a provider who is familiar with what is safe for pregnancy and breastfeeding. It should be made note that if you are pregnant or breastfeeding, you cannot just take vitamins over the counter just because you've heard they are good. None of these supplements are FDA regulated in this country. In case any of you guys didn't know, even baby probiotics, which I love baby probiotics, or baby vitamin D, which is recommended if you're breastfeeding and you should be giving your baby if you're breastfeeding. Those are not FDA regulated. So none of this stuff is being tested. So you cannot just take stuff like that you've heard from your friend work for them, because just because it's a vitamin does not mean it's safe. Okay. For those of you who are still on, if you have any last minute questions, please put them into the chat, because I don't have any more questions from the video this week. I want to let you know we are on Facebook, Instagram, and Twitter. Please, any questions during the week, put them onto the videos. We read them here. Like, I read a lot of them. We answer them. We will take suggestions off of them to make videos. In fact, some of our best videos have come from suggestions that you guys have given us. Share the channel with your friends and family, okay? Please. And like and subscribe. Subscribing really helps all the content providers out, like myself. And just so you guys know, we have been approved here at the Maternity Mentor to be a part of the YouTube Health platform. This is a platform YouTube is putting together where they are taking healthcare professionals like myself, and we are going through a screening process to be vetted so that you, the viewer, can know that I am a legitimate healthcare provider. I have a license, and the information that you are receiving is legitimate. I'm not random person A off of the street. For those of you who stuck around to the end, I am going to give you a sneak peek at tomorrow's video. So tomorrow's video are the top 10 gifts for you to consider to give the new mom after she gives birth, and no, they are not related to baby. So if you're about to give birth, if maybe you just gave birth like Gabriella, I would check this video out. These are my top 10 suggestions on things that would be amazing for the new mom after she gives birth. With that being said, I am so glad you're here. I'm so grateful for all of your support. I really appreciate it. This is my passion, and I love what I do. I'm Dr. Samantha, the Maternity Mentor. Bye for now.